Welcome, everyone. Thank you for joining us today. We would like to welcome you to another NetHope Solutions Center webinar, and today we are discussing ICT for COVID-19 response, lessons learned from digital applications for disease monitoring and preparedness. Today we're joined by representatives from Everyone Mobile, World Vision Sierra Leone, Farm Access Foundation, D-Tree International, and Living Goods. And before we get started, I'd like to go over a few housekeeping guidelines for our session today. Please keep this interactive. Please open your Zoom chat window and add any comments or questions you have there for our Q&A discussion toward the end of the hour. Later today or tomorrow, you'll receive a follow-up email with a link to the recording for this session and any collateral that corresponds with our session today. And we would appreciate it if you would fill out our webinar satisfaction poll that's presented at the end of the webinar. Your feedback is very important to us. And with that, I will turn it over to my colleague Sonia Rutzel from Catholic Relief Services.
Thank you very much, Madeleine, and thank you very much, NetHope, for facilitating this ICT4D webinar with us. It's now my pleasure to introduce you to our expert speaker panel for this session on ICT for COVID-19 response and preparedness. I just want to say that most of these sessions were prepared before we had the first COVID-19 case. So they were all accepted speakers for the ICT4D conference, which was supposed to happen today in Abuja, but obviously we had to postpone it. And kindly all speakers confirmed that they would like to share their initiatives and also particularly share how their initiatives are relevant to current COVID-19 response and preparedness. So thank you very much for adjusting your presentations and making them very relevant to today's time. So without further ado, I'd like to introduce you to our speakers. We have Abby Gleek. She's the Director of Digital Strategy at Everyone Mobile. Robert Cavani, he's the Program Coordinator of World Vision in Sierra Leone. Njide Nidili, she's the Country Director of Nigeria for Farm Access Foundation. Rebecca Littner, Program Manager at D-Tree International. And Dr. Andrew Karlyn, the Chief Impact Officer at Living Goods. So thank you very much for joining us today. And Abby, I would like to ask you to share with you your 10-day hand washing challenge. Thank you, the floor is yours.
Great, thank you very much, Sonia. So I'm here to talk to you about digital approaches to driving real-life behavior change, what we've learned and how we're using it now in our COVID-19 prevention work. So I'll draw from our experience designing and implementing a hand washing challenge within our broader hygiene digital behavior change platform for mums and mums-to-be in the informal settlements of Nairobi. So I'll start by telling you about UAFIA. Our vision for the UAFIA program was that for all families in the slums of Nairobi to be well nourished and free from infection. And we aim to achieve this through UAFIA by supporting mums and mums-to-be to care well from their families through 4 healthy behaviors, one of which is hand washing with soap at the 5 key moments. So in real life, behaviors are complex and messy. They're shaped not only by what you know, but by how you feel. So we took the time to consult with our target users on what shapes their behaviors in their context. And it turns out they do already have a pretty good level of knowledge about the importance of hand washing behavior. However, the barrier to them enacting that behavior came down to a lack of self-confidence, particularly in their ability to perform the behavior when needed. So we designed UAFIA to help these Kenyan mums find their agency in changing the way they care for their families. It's designed to build that sense of confidence and self-efficacy. One of the methods we designed was the hand washing challenge. If I could have the next slide, please. It was inspired by the sophisticated smartphone apps which influence behavior change through habit creation. And these habit tracking apps help users develop positive habits and promote positive behavior change by helping users set and achieve goals. However, for the most part, they require the use of smartphones, and where they offer a visually rich, beautiful experience, this requires a lot of data, and they can sometimes cost money to download them. So we wanted to bring the benefits of these sophisticated habit tracking apps to our low-income UAFIA community. So here's how it worked. The handwashing challenge offers a way for our users to model out the desired behavior through simple daily challenges. For instance, today, make sure your children wash their hands before eating. The mums perform the behavior in the real world, then use the challenge tool to track their own progress. On completion of their daily challenge, users receive a thank you message, confirmation of their progress along the steps of the challenge, and an additional piece of information in the form of a did you know? And then the next day, the next challenge will appear. So by returning over multiple days, the mums start to create and reinforce the habit. Now, this design draws from techniques in the Behavior Change Wheel by Mickey et al., as well as the behavior change levers employed by Unilever and Lifebuoy in their Way of Life campaign. We created awareness by introducing a hand-washing theme across the UAFIA site and providing educational content all about health and hygiene, and this also served as a demand generation purpose. We encourage commitment by asking users to take a hand-washing pledge when they complete their challenge and making a commitment to hand-washing going forwards. By getting users to repeat the habit performance each day, we reinforce the habit, and we provided a reward through success messages and social status within the site for challenge completers. As it's all built within the UAFIA mobile site using the Everyone mobile platform, it's fully optimized for basic internet-enabled feature phones and a low data version for our smartphone users who may still struggle with the cost of data. So here are some key lessons. If we could have the next slide, please. It's certainly effective as a low-cost way to build self-efficacy around hand-washing behavior, as you can see from some of the feedback we received directly from our users. It worked especially well as it was integrated within an existing site with a clear value proposition. It was integrated into their current experience and simply promoted as something new to try. So this meant there was no need to onboard users. It was a really simple step for them already familiar with the site to try it out. It sat really well alongside our other digital behavior change tools, such as e-learning and peer support mechanisms, as part of a nuanced set of approaches. And having the UAFIA community around it to support each other through the challenge was also really valuable. And a final lesson was that simplicity is key. Simplicity of design, functionality, and the message. So now, how to take this experience and these lessons to apply to the COVID response. Could I have the next slide, please? There is an urgent need to provide accurate, endorsed, and digestible information to vulnerable communities and to establish the critical hygiene behaviors that will protect individuals and their families. Communities are being bombarded with information on COVID-19 from a range of different sources, often contradictory or misleading. Even before the current crisis, there were barriers to effective hygiene behavior practices, and simply broadcasting more information at communities is insufficient on its own. Lack of confidence and that sense of self-efficacy is critical barriers to overcome. So in response, Everyone Mobile has already invested in building a basic community-facing site, one in English and one in Kenyan Kiswahili. You can see the URLs on this slide, so please do go and visit them and share them with your networks. This site contains the most important information from the WHO about the virus and how the users can protect themselves and their families. It contains facts to generate awareness and stop the spread of misinformation, an advice section to provide support and tips on how to keep safe, a section on how to get involved to encourage real-life behavior change on hand washing, and links to the latest local government hotlines and the latest local stats. So we're now seeking partnerships to help us with the next phases, which can follow rapidly, This will allow us to evolve this site into a more deeply engaging digital behaviour change platform using all of our lessons from UAFIA and the hand washing challenge. So we want to bring in the more nuanced SBCC techniques using a socio-ecological model, bring in peer interaction where users can share their experiences, tips and reassurances, more structured digital learning journeys, and critically, the personal behaviour tracker tool based on the hand washing challenge to model hand washing and hygiene behaviours and allow users to build and track their own healthy behaviours. And through partnerships, we're looking to localise and contextualise this for multi-country rollout at scale. So my contact details are there. Please do get in touch if this is something you'd like to explore with us. Thank you.
Thank you very much, Abby. And also a quick note before we move on to Robert's case study. We will share those slides afterwards. And if you have any questions for any of the speakers, please post them in the chat room. So Robert, I would like to ask you to please share with you your oversight on how to use mobile training and support services, particularly with your work in Sierra Leone. Thank you.
Thank you, Sonia. This is Robert speaking. I'd like to begin by talking to you about the EBODAC program, or the EBODAC Consortium. It's a consortium of 4 organizations that includes World Vision, the London School of Hygiene and Tropical Medicine, Grameen Foundation, and Janssen Pharmaceuticals. This consortium came into existence in 2014 after the outbreak of Ebola in West Africa. And the purpose or the objective of this project was to develop communication and community engagement strategies and tools, plus enabling technology platforms that can be used to deploy a successful vaccine. So it's a project that was born out of challenges that had been observed during the response to Ebola in West Africa. And one of the things that we observed, even based on what's happening today, one of the don'ts in a pandemic is you do not need to have crowds or organized people coming into organized spaces. We therefore thought about how could we train community health workers while keeping in line with the social distancing, the curfews and the lockdowns that existed in Sierra Leone and West Africa in general. That's how we came up with the innovation to have the mobile training support services for community health workers, which is called MOTS. It's an open source platform. The purpose is mainly to strengthen community health work network, provide refresher training or even basic training to CHWs, but also to provide reporting capacities. Next slide, please. MOTS works in a very basic way. It's basically one, you get your CHW selected, which usually is already done by the Ministry of Health. You have a Ministry of Health training modules and content, which have already been developed. You translate these modules into local languages for which the CHWs prefer. In this case, if it was COVID-19 prevention messages, you'd take the messages that the ministry has adapted or adopted from WHO, get them translated, and then the CHWs will receive them remotely. They listen to these modules using the IVR, and then you can remotely also generate reports. Next slide, please. The key lessons we have learned as we developed MODS is one of the things that worked really well in our development of this platform is that we involved the CHW or the end users in the development of the platform. We didn't develop a platform and take it to the CHWs to use it. We actually had design workshops with them in the field to try and understand what would be the alternative ways of training apart from the classroom. How would a phone replace a classroom, and how they want to receive remote trainings. So the user human-centered design approach really addresses unique needs of CHWs. That was a key lessons learned. The second one is always endeavor to develop digital platforms that integrate both the service delivery, in this case it was training, and the digital interactive messages, but also the operational support functions. For instance, you wouldn't want to develop a platform that only provides training, but the supervision of the CHWs is not integrated within the platform. This particular platform, MOTS, does both the training, which is the service delivered and broadcasting, but also incorporates all the other structures, support functions that the CHWs need to do their work successfully. The third learning is the modules need to build on 1 to 2 objectives. Mainly here, the key message: please avoid information overload, because the CHWs won't have a lot of time to listen to all this information if you overload them. Taking languages, taking the trainings in their preferred local language became out as very key and easier for them to understand and appreciate the trainings. The involvement of the government right from the start, which meant that we had our sustainability plan inbuilt in the implementation of MOTS right from the beginning, was very successful because we used all the government structures in the implementation by the project supporting. It was another key lesson learned. We also learned that where these trainings were being conducted, we could see that males were less likely to complete the training compared to their females, meaning that though the platform seemed to give, seemed to be maybe less comfortable for males, but it also promoted the women, the female CHWs to use it. The last key lesson learned that I would like to emphasize: always have your practical sustainability plan as part of your technology development design, and not simply part of the project closeout. Next slide, please. How has MOTS been deployed so far? We did a pilot in Sierra Leone for 125 CHWs. We then did a scale up in Sierra Leone again of 811 CHWs together with the government of Sierra Leone. The government of Sierra Leone has now taken over MOTS and it's integrated its digital platforms for CHWs, and they will be able to implement this even after the project has ended. They have been able to invest in the integration. Then we did share this platform with some governments in Africa where this project has been implemented, and Rwanda has adapted this platform for training of its CHWs during the Ebola vaccine deployment campaign that they are conducting. Next slide, please. How can you use MOTS for COVID-19? One, it's a very nice tool in the era of social distancing, curfews, and lockdowns that you can use to remotely train CHWs and other frontline workers in any key prevention messages around COVID prevention. The second one, you can still use it to do surveys to give you the information that you need to plan for your COVID response programs. For instance, in Kinshasa, we are doing, World Vision is going to use it to do a household survey on food insecurity. In Sierra Leone, like you've seen in the first point, the government is using it to train 6,000 CHWs in COVID prevention. And then you can also use it for emergency broadcasts, which is basically sending out messages and also tracking rumors and developing appropriate messages to mitigate those rumors. And fourth, you can also use it for your response interventions, especially quantitative data. Next slide, please. Yeah, next slide, please. That's the guys who graduated. Lastly, we have done some research around the work we have implemented in Sierra Leone, and you'll be able to read more about the successes, lessons learned, and the challenges that we faced in the implementation of the project. These papers will be shared with you as part of the extension for this learning session. Thank you so much.
Thank you very much, Robert. Thank you for sharing all your insights, and thank you everyone for sharing your questions for Robert. In case we don't get through to all of the questions, we will forward those to the speakers and ask them if they have some answers for us and share those in a post-webinar summary. Our next speaker, NG Day, will be sharing a mobile tool for tuberculosis screening in Nigeria. NGDay, the platform is yours.
Thank you so much, Sonia, and it's a pleasure being here. First of all, just to talk quickly about Farm Access Foundation, we are an international NGO headquartered in Amsterdam, but most of our implementation is in Africa. We're in 4 African countries, Nigeria, Ghana, Tanzania, and Kenya. And in Nigeria, next slide, please. And in Nigeria, interestingly, we do quite a bit of programs to support both governments and donor organizations to enable access to healthcare, quality healthcare services, especially for the bottom of the pyramid. And for that, we provide interventions all along the healthcare delivery track, but we use digital as our anchor and an enabler. So you can see some of the activities that we do, but I won't go into all of that. Next slide, please. So the MATS tool is actually a mobile application for tuberculosis screening. This program was developed in partnership with a few of our donors, more so through one of our vertical programs. Why? Because Nigeria was listed as one of the 16 countries with the highest burden of TB and accounts for about 8% of the 4.3 million missed cases globally. So what happened is that normally there's a paper tool that is used to diagnose patients, but we took this tool and we digitized it. This tool is now in the hands of healthcare workers, patent medicine vendors, because first of all, in order to capture the TB cases officially, they have to have been treated or presumed positive. So this was a way to kind of identify those cases that are being missed by digitizing the paper-based checklist. So we digitized the checklist and put it in the hands of community workers, medicine vendors. So in the community, you can have them go through an algorithm answering specific questions. And if they answer some questions a certain way and the algorithm presumes them positive, then they're referred to clinics that are nearby, that are already trained and designated TB sites. Now to develop this app, we had to consult very deeply with some of the organizations, including the healthcare facilities as well as the healthcare workers. There was a lot of stigmatization going on. People didn't want to go into the clinics because some clinics were designated as tuberculosis clinics. So nobody wanted to go near those clinics. So this was a way to discreetly test some of the patients by going through this algorithm. And it was a very iterative test. So some of our partners included the Global Fund. They provided some of the funding to develop this app. KNCV, the government of Lagos State, the federal government of Nigeria, the National Tuberculosis Program, and the Institute of Human Virology Nigeria. Now, in the process of consultation and also dealing with the healthcare workers, understanding how they use the system, understanding the kinds of outputs that they're looking for, we ended up having the federal government of Nigeria adopt the MATS tool, and is currently being used in 21 states in Nigeria. Next slide, please. So this is just to show our process that typically we don't go to our offices and design a program. We do a lot of research, trying to get the users involved, the experts involved, what is the algorithm, best practice, and the clinical flow to be able to program it properly. So basically we use a user-centered approach, but most importantly is using the appropriate technology. Nigeria is a country of over 200 million people, but there are 150 million active phone lines. So basically you have a tool in the hands of majority of the people that can be used to provide access to healthcare services or access to information to enable them better access to healthcare services. Next slide, please. So just to put side by side the process we went through. So for the MATS tool, we kind of used a similar approach. In fact, we started developing a COVID chat box, but very quickly realized that there's so many tools out there, even though Nigeria doesn't have as much cases as the rest of the world. We also realized that maybe we don't have the time to start developing a tool can we adopt a tool that's already existing, but we can then find a partner who can program for future phones using USSD codes. Unfortunately, the people using feature phones are in the majority, but yet till date, I don't think I've seen any COVID application that is running on a feature phone. So that is one area we're looking to engage any developer or any company that has already developed an application. I want to transition to USSD for Africa, but this is a need area. So what we're trying to do now is to focus on advice, looking at the data that is already being generated and trying to use that data to advise the government on what to do. In Lagos, for example, we are part of the think tank that advises the Lagos state government, the epicenter, on how to design the patient journey. And right now, the journey is totally being digitized, with the starting point being mobile phone screening apps. So I think that it has a real value for COVID-19. Next slide, please. So I wanted to focus very quickly on some of the lessons we've learned. And I think that these lessons need to be factored in, because COVID will come and pass at some point. Well, we have to look at the peculiarities of Africa, especially Nigeria, where 70% of out-of-pocket payment is, is what the people have to deal with because of the low income. So using this maths tool, when we started, it was just an algorithm to kind of identify possibly TB cases. But now what has happened, because it was put in the hands of a lot of healthcare workers, more cases are being found. The cases are being programmed, so it really don't have to be a doctor, but at least if you're a healthcare worker, you can go through the algorithm and it guides you. You don't even have to think, just ask the questions and the answers will lead you to the next question, and so on and so forth. So it gives you a better chance of getting a consistent result using the algorithm already programmed in the tool. Another thing is that it helps with referrals. So using a GIS map, all the facilities that are able to provide TB services are programmed into the phone. So you don't really have to look. Once it's positive, the information is transferred to the clinic, and the clinic already has the information of the patient before the patient gets there. And that way, the transition is very seamless. It also helps identify hotspots, because at the back end, we are looking at this data and we're seeing where there's a concentration of positive cases, and then there's kind of intervention, or we advise the government on how to intervene or where to intervene, so that resources are directed to the places that are needed the most. Of course, only positive cases are triaged. But also interestingly, with the support of Global Fund, who is really at the back, trying to increase case finding for TB in Nigeria, we've integrated a poverty mapping tool, which is also an algorithm that determines whether you can even afford, your level of poverty, basically. So depending on your level of poverty, you can get free access to TB services, or you have to pay yourself if you're found to be wealthy enough. So you find that you can now integrate, kind of benefits or cash transfers or additional benefits to this application, just because there's a poverty mapping there. Then also in terms of oversupply of drugs, we tend to, here in Nigeria, tend to self-medicate. We go to the patent medicine vendors. I think I have malaria. I think I have, any other ailment, and we buy the medication off over the counter, even when they're not supposed to be over the counter. So this, in a sense, would direct you to where you need to get treated, reduces oversupply of drugs, there's more accurate diagnosis, and so on. And of course, reduces waste. And this again gives us real-time information that we are feeding back to the Ministry of Health, and they're using this information to program their intervention. And what we are also trying to do is to use this kind of tool to convert vertical funding into horizontal funding. So we are essentially advocating for health insurance, but if we can show that using a tool like this, someone that has TB that can't afford to pay, then we can refer that particular person to the state, who then picks up the payment of their premium as either a subsidy or full payment. Well, that way you can quickly identify the people that need help and the people who need some kind of subsidy, or those who don't need help at all. So this has kind of guided really our principle in terms of how do we integrate vertical programs into an insurance program that takes care of the whole human being? How do we empower the facilities, not just with our safe care methodology, not just to take on specific interventions, but to improve quality around the whole clinic and so on. So this has been really a very important tool in our journey towards integration of disease-specific programs into an overall health insurance program. Next slide, please. So just, this is just, I'm sure anybody who has any idea of digital would probably go through this kind of process or lessons learned, but it's really important to re-emphasize that as you're designing a tool, you know, that it's targeted, you know what the outcome you want, and you have someone who is going to adopt the program and scale it or integrate it into an existing program. There needs to be engagement of the users, the end users, and the healthcare workers. If there's a disconnect, then it really doesn't work. Understanding their peculiarities, as in Nigeria now, we're understanding that quite a number of users have feature phones. So there's no point, you know, spending all your energy programming for high-end smartphones when half the people have feature phones. So how can we utilize that knowledge to program and give them appropriate technology? Then of course you have to prototype, pilot, test, and continue to improve the system until you have a solution that can be rolled out. But ultimately, in Nigeria, the private sector unfortunately drives quite a lot of the healthcare delivery and the interventions in collaboration with developmental partners. So we have a responsibility to develop these tools and find a way to pass it on to the government or support the government to roll them out. So basically, these are some of the areas that I want to highlight with the use of the MAX tool. Thank you.
Thank you very much, Njide. Our next contribution will also be looking at lessons learned from tuberculosis management system using near-field communication and mobile technologies. So Rebecca, over to you to share your insights from D3.
Thank you, Sonia. Thank you. Yes, so I'll be sharing about our tuberculosis management program among migrants using mobile and NFC technology. You can move on to the next slide. I'm here with D3 International. D3 is a global digital health organization working at the intersection of health and technology to improve health systems. And through our work, especially as we're confronting COVID-19 in various countries, we're seeing the importance of taking a systems building approach and working across all levels of the health system, from the community to the provider, all the way up to the national level with the government. And we're also seeing how digital can play an important role in COVID-19 management. So I'll share about one of our programs and then some of the considerations for COVID. Next slide. This program focuses on tuberculosis management to improve outcomes for migrants on the Thai-Myanmar border, working with our partner Alight through the Stop TB partnership. The focus on migrants is particularly important. There are over 2 million Myanmar migrants in Thailand, and these migrants are incredibly vulnerable to infectious diseases like tuberculosis and COVID-19. This is due to a variety of factors. Migrants are highly mobile. There are language barriers as they're traveling across borders. And as a result, there's high discrimination, which makes it more difficult to access the care that they need. Typically, they have poor socioeconomic backgrounds and live in crowded settings with poor sanitation. And there are also challenges with migrant identification and documentation and connectivity challenges as well. So because of all this, we did see lower adherence to treatments among this population. Prior to our program, 66% of migrants completed treatment in one of the intervention locations. And then after implementing our program just a year ago, we've already seen significant improvements with over 80% treatment success. So this really shows the potential for bringing this type of solution to other disease contexts like COVID-19. Next slide. The solution is mobile and NFC technology. The mobile component is an application used by the community health worker to register a patient and conduct home visits to monitor medications and danger signs. And the NFC component stays with the patient. So what is NFC? NFC stands for Near Field Communication. It's a low-cost digital storage device, and you may actually run into this kind of technology in your everyday life, like an identity card or a credit card, but essentially it's a data storage device. How does it work? After a health worker uses the application, say for patient visits, the worker then simply taps the phone to the NFC card to store the patient information on the card. The patient then keeps the card and brings it with him or her to any visit. And then a new health worker can tap the card and pull up the latest information. So it's very seamless, this data sharing. There are a few key benefits of NFC. One is that it works in low connectivity settings because you don't need connectivity to pull up information from the card. Also, it can be used as an identification method since the information on the card is unique. Identification was seen as a challenge during the Ebola crisis, especially for migrants. So considering that, it will likely be a challenge for COVID as well. So something to watch out for. And another key point is that it's language independent. So think about when a migrant travels across borders, the health worker in one country like Myanmar can pull up the patient record in Burmese, but then if a patient travels to Thailand, a health worker there can pull up the record in Thai. So that helps with the language barriers and the access to care issues. Next slide. Here, demonstrating some scenarios that are important for migrants. Within one district, we see that a patient can go to multiple health workers. And there's a lot of movement among migrants. So even when a patient transfers from one district to another, the health workers in the new district can pull up the record from the NFC card. So here, just really highlighting the importance of NFC for this continuity of care. Next slide. I've mentioned several benefits so far for patients and providers. So I'll highlight some benefits here for program managers. So program managers, these are supervisors, district and government leaders, program teams. One benefit is that it's low cost at about $1 to $2 a piece. The data is secure and encrypted on the card. And lastly, information from the program can be used to track continuity of care and patient movements, which as we know is important for migrants. Now bringing it back to COVID-19, here are some key considerations. Migrants are highly mobile and therefore likely vectors of infectious disease. So an outbreak of COVID could spread easily and widely among this population. They are a high-risk population themselves, considering their living conditions, which all make it difficult to adhere to social distancing, isolation, and sanitation, and other kinds of preventive practices. And longitudinal follow-up is also a challenge, including contact tracing and monitoring, important for COVID-19. So one takeaway here is that mobile and NFC technology can support migrants or even similar populations like refugees. And a few key things that are important I've shared throughout. So it works in low connectivity settings, it's multilingual, so it supports patient movement, and it supports longitudinal care. So for example, related to COVID, if someone is identified with symptoms in the community by a community health worker and then goes to a health facility, the health facility worker can simply pull up the record from the NFC card and continue next steps in management. Next slide. Finally, ending on a quote here from UNICEF, which highlights the migrant population as a priority. I'll read a bit of it. Any public health response to the pandemic, COVID-19, should reach the most vulnerable, including refugees, migrants, and those who are internally displaced. So we do see the need and the potential for this type of solution for COVID-19. We're working with partners to think about how to leverage NFC further, and we're also open to collaborate. If anyone has questions or sees the need for this type of solution, I'm happy to discuss. So thank you, and I'll pass it back to Sonia.
Thank you very much, Rebecca. And our final contribution to our list of innovations and case studies will be from Andrew at Living Goods. Andrew will be sharing testing mHealth solutions at the last mile. Thank you very much, Andrew.
Thanks, Sonia. And I'm happy to present today insights from two initiatives that we carried out over the past year in Western Kenya. So Living Goods is a Nairobi-based nonprofit organization with country operations in Kenya, Uganda, Myanmar, and also an advisory presence in Sierra Leone and Burkina Faso. Our goal, we aim to save lives at scale by supporting digitally empowered community health workers. And we work with governments and private sector partners to leverage smart mobile technology, strengthen performance management, and innovate to deliver cost-effective, high-quality, impactful services, health services. The solutions that we tested were funded under the Innovation Network, which is a Bill and Melinda Gates Foundation funded project, 36-month-long initiative, partnering with Medic Mobile and other local partners. And the objective is to research test barriers to scale for new health innovations and to prove that the opportunity for diagnostic and health technologies can be extended from the lab to the last mile. The Innovation Network works by sponsoring tests of concepts and technologies at the community level. And what we did in this case was we tested two linked concepts. One is, as we called, the closed loop referral program, which linked facility and community, linking the smart health application in the hands of the community health worker with facility-based EMR systems and tablets. And this was specifically for use cases for maternal, neonatal, and child health and integrated community case management. The second linked activity was to introduce HIV self-testing for referrals and follow-up at the community level using RDT testing technology. So what I'll share with you, next slide, is not necessarily what went well with the studies, but what went wrong. And part of this really informed our innovation process. What we saw with the closed loop referrals was that we didn't see any significant improvement in CHW visits or completed referrals. But what we did see was a significant increase in household visits by CHWs post-referral. And secondly, with the HIV self-testing, we saw that the majority of respondents within the self-testing group had not used the self-testing kits as we expected them to do so during the time of the evaluation. Rather, the households would accept the kit and then go to the facility or go to a preferred provider in order to get the test. And we, as we looked at the evaluation results, we, of course, wondered why they didn't work in the way that we thought they would. We came back to our innovation cycle and our innovation process to really understand what went wrong and what went well in that setting. Next slide, please. So what we learned was rather obvious in some ways, but in retrospect, you constantly are checking the reality, is that we really needed to understand the interplay between community needs and the needs of the organization to drive innovation process and to test feasibility. So the first question we asked ourselves, is there a clear need? Is the community need expressed? Do we adequately go out to the community and get the kind of input that we needed? But secondly, in the decision about whether it aligned with our strategic focus, we're very focused on supporting the link between facility and community, but we didn't always focus on whether the technical and organizational questions around that feasibility really were supported by what the needs were at, for instance, at the facility. So when we went back, we asked the facility, why didn't this work? And ultimately what we heard was that the health workers, the frontline health workers sitting in the facility, the referral nurses, saw this as one of many activities that came and went within the community, whereas the community health workers saw it as a way of gaining legitimacy in the eyes of both the community as well as the facility. Next slide, please. So where did we focus? When we looked at the innovation life cycle, and this is the life cycle as laid out by IDIA, we really were very focused on this middle piece of proof of concept to transition to scale, and didn't always start early enough in the cycle, in the ideation and research and development cycle, to go back to that community. So we're very focused on proving the concept and showing how it could be onboarded onto our technology without really thinking about what happened, what came before, and what came after. Next slide, please. So what we recognized was that while at times we tried to be somewhat disruptive in how we applied our technology, we also felt that the greatest benefit, particularly for an operational entity such as Living Goods, is to look at both the everyday and incremental innovations that we could really drive with consistent community engagement and updating of both our technology and our use cases. And I think this is where I would turn to the COVID response, because both of these activities of rapid testing and facility to community linkages happened pre-coronavirus. And now we're faced with this challenge of, how do we go out and listen to clients when we can't easily get to the field? Western Kenya is not nearly as accessible as it was 3 months ago. And how do we engage governments and local partners in providing the input so that the health facility is actually providing the insights needed in order to shape these solutions? And so one question will be, and we will operationalize, is how do you take qualitative and HCD techniques to really understand user journey using remote monitoring types of engagement tools, whether that's two-way SMS, IP messaging, or even Zoom-based or other teleconference-based focus group discussions. Let me pause and leave it there, but thank you very much for your attention. Sonia.
Thank you very much, Andrew, and particularly thank you for being brave enough to not always share good practice, but also lessons learned when things did not go fantastic. Big thank you to all of the speakers, and we received quite a number of questions, so I would say let's get started. My first question is for Abby, but also I think this is also a question where maybe some of the other speakers want to contribute. So feel free to get off mute afterwards if you'd like to add your comment. Abby, the question is, how did you get buy-in from the local governments, the communities, and the users? The person asking the question said that in their country context, there are so many apps developed, but not a lot of buy-in.
Hi, yeah, thank you very much for the question. So for a little bit of context, obviously I had to introduce it very, very quickly. So this was funded under the Transform Partnership, which is a public-private partnership between DFID and Unilever. So we worked very closely in the implementation and design, particularly with Unilever Kenya. So that's helped with our rollout approach and sort of local relationships. In terms of building sort of trust and buy-in from the local communities and the users themselves, so we took a human human-centered design approach, as we do with all our programs for UAFIA. We did a research with the community front to make sure that what we were designing would be not just impactful, but accessible and exciting and engaging for them, and was going to offer value for them. So we co-created the approach with a sample of our users, and then we always gather feedback and iterate as we go. We promote UAFIA to mums and mums-to-be through a range of trusted community actors, and we also have a UAFIA ambassador program where some of our super users can help promote UAFIA to their peers as well.
Thank you, Abby. Do any of the other speakers like to add some comments, given that this is a common concern, to get buy-in? Okay, in this case, let's move on to the next question. Also, thank you very much to all the speakers who are already answering some of the questions in the chat. I can see you're very busy. We will share a lot of this information afterwards in a summary. There has been also a lot of questions around data privacy issues and concerns. So some of them, I think, Robert, you also answered some of the questions. So can I maybe ask the question to you? Does not cover user data privacy issues as per local regulations with the various countries. What do you have in place with regards to data protection? Thank you.
One of the things that this is Robert speaking, one of the things that we did in Sierra Leone and what we have done in all the countries where we are supporting the deployment of bots, we do a regulatory authority compliance requirements assessment to understand all the issues around data security, protection, including transfer. When we have identified the critical requirements that we need to comply with, then we would have engagements with the Minister of Health. In most cases, we have done this with the appropriate ICT or communication authority within that country. In Sierra Leone, it was NATCOM and the Directorate of Planning, the Minister of Health, and then the Director of Primary Care, and then talk through how the implementation of the platform would comply with the requirements within the country, and then see the resources that are available within the country and the resources that were available within the project. But one way of going around this in Sierra Leone, apart from making sure we got government approvals, we got government approvals on some of the challenges that existed. For instance, Sierra Leone did not have a national database that would host a lot of the innovations that were going on in the country. Some of the data for mods was being hosted out of the country, so we got approval for that. But part of the sustainability plan, which we discussed with the government right at the start, was for the ministry to set up a database that would host the final pilot deployment and application of mods, which we have successfully done. They were able to give us 2 software engineers who have worked on this, and we're in the final processes of them officially managing and managing mods throughout, including data hosting within the country.
Thank you, Robert. Rebecca, I also have a question for you regarding data protection. So the question is the near-field technology data encrypted, and is it able to be read by unwanted users? Can you talk a little bit about data protection from your end?
Yeah, data protection is incredibly important in this program, any program, but for migrants in particularly, we were very careful with what kind of data was stored on the phone and also on the card, really keeping to what's important for the management of the case. The card itself is encrypted, so the information on that card can only be accessed by users of the program who have the associated mobile application. So that's one key point. And I saw some questions in there too about if the NFC card is lost, what happens? the data is still available on the phone. So what can happen is the NFC card can be replaced simply by tapping the information on the phone to the NFC card. The consideration is whether or not the users have synced. So if users have synced the data, then the full record is available on the card, is available on the phone, and therefore can be updated on the card again. If users didn't sync, that's when some of the information won't be available on the phone at that time. But yeah, so it is important. It's encrypted, and very important part of this program.
Thank you very much. One of the questions is for all panelists. So first, well, feel free for everybody to chip in, but I will first ask NG Day for your opinion. How do you address low digital skill level of the rural communities that the solution is targeted? How do you deal with limited digital literacy? Sorry.
Yeah, so we try to, first of all, to train the healthcare workers and the CHUs within the community. As you know, our own MATS tool is not really within the community. It's handled by the healthcare workers. So they are the ones that actually do the screening. And of course, to do the screening, it's translated into several languages, or they're able to communicate in different languages with the community members or those who are going to be screened. What's important to note that, you know, in as much as we are pushing for digital, we know that very much in the rural communities, a lot of the people there have phones, but they're feature phones, but they do know how to use it. So it's, the literacy level may not be there, but it's very important to simplify the application. So it's either a yes or a no, or translated in a manner that they can understand. So that's how we deal with it at this moment.
Thank you. Andrew, do you have anything to add, particularly since your initiative included self-testing? How did you deal with different levels of digital literacy?
Well, I think the situation is much like was just explained, is that we work closely and through the community health worker as that ambassador at the community level. But of course, the materials and the way that the workflows and protocols are really built are to engage the individual and household in a very straightforward manner, using local language, of course, and using the appropriate resources at hand. I think one of the things that we learned from the closed loop was that what we weren't getting was really the direct requests coming from the client. So as a follow-on, and the ATD and other community work that research that we had done following this, we've designed a program around a community-initiated health assessment that effectively is a pull mechanism. So it's really linking, instead, not just linking the facility to the community health worker to the community, it's on a feature phone, the individual through an SMS request or even a phone call can call the community health worker and ask whether, and inquire if they need help or if they have a problem. And it's this approach, this pull method, that we're very interested in using as part of the COVID response. So initiating self-assessments, and those self-assessments are linked to specific workflows that report to health facility and central level, but also ensure that appropriate resources. What the community health worker does well is they do very well at getting to the household to do the further in-depth workflows and health processes. So our focus really ultimately drove down to getting those user needs at multiple stakeholder levels.
Thank you very much, Andrew. And thank you very much to all of our speakers for sharing your initiatives and your insights and how they can be adapted to the current COVID response and preparedness. Thank you for all the attendees. We will reconvene here on the NetHope platform under the ICT4D webinar series this Thursday with the donor panel on data protection priorities and expectations. And then again also on Tuesday, May 5th, on using digital technology to help fight COVID-19 miscommunication. And I also like to highlight that the Global Digital Development Forum will take place on May 6th. This is a all-day virtual conference with 16 hours of ICT4D content. We will share with you the link to the forum. You can also see it here. Yeah, please register. I think there is a lot of exciting content for you across different regions of this world. And thank you all very much for your interest, and I hope to see you soon. And a big thank you also to NetHope for facilitating us. Thank you. Goodbye.
Thank you very much, Sonia, and thank you to all of our speakers and to all of the attendees for your excellent interactions today. Please be sure to complete our webinar satisfaction poll. We appreciate your feedback, and don't forget you'll look for a follow-up email with the link to the recording and the collateral and links that were provided during today's session. I'm Madeline No with NetHope, and have a great rest of your day. Thank you.